Good morning. Today I am going to present on behalf of Medicine 5, the double-edged sword. Presenting Mrs. Y, 50 years old homemaker from Kanchipuram, presented with cough for 5 days, progressive dyspnea and exhaustion for 5 days, bilateral lower limb swelling for 5 days. She was well before 5 days, then developed cough with productive sputum associated with fever, which is high-grade intermittent and chills. Then developed progressive dyspnea and exhaustion, worsened over last 2 days from NOHA class 2 to class 4, associated with orthopnea and PND. There is no history of chest pain or palpitation. Then she developed bilateral lower limb swelling, which is insidious in onset, gradually progressive, and not associated with pain. Past history-wise, she is a known case of diabetes mellitus for the past 5 years, the non-compliant with drugs. Invasive, she is also diagnosed with invasive ductal carcinoma of left breast before 2017, which is ER-PR positive with HER2 positive, for which she underwent a neoadjuvant chemotherapy followed by left side modified radical mastectomy. She is also a known case of dilated cardiomyopathy for 5 years. Family history-wise, her mother passed away at the age of 60 due to coronary artery disease. Personal history, she is post-menopause for last 5 years. Examination revealed a significant examination findings like JVP was elevated and bilateral pitting pedal edema up to angle is noted. Cardiovascular system examination relieved apex beat at 5th intercostal space, 1 centimeter lateral to mid-axillary line. There is also loud P2 noted. Respiratory system examination revealed left inter and infrascapular bronchial breath sounds with whispering pectoralici and increased vocal resonance. So at this point, summarizing, some 50 years old female with a past history of dilated cardiomyopathy, poorly controlled sugars, now presenting with cough with expectoration and fever, followed by that worsening breathlessness and pedal edema. The straightforward case of acute decompensated heart failure precipitated by community-acquired pneumonia. The differential I consider for this dilated cardiomyopathy at this point was ischemic cardiomyopathy, toxin-induced cardiomyopathy, or it could be a valvular heart disease, genetic causes or idiopathic causes. So what could be the differential for this? So there is an entity called drug-induced cardiomyopathy. The toxin-induced cardiomyopathy could be due to alcohol, catecholamines like amphetamines, cocaine, and chemotherapeutic agents like anthracyclines and trastuzumab. Other therapeutic agents such as hydroxychloroquine, chloroquine also related, has a case report suggesting of dilated cardiomyopathy related to this drugs. Drug of misuse like anabolic steroids also associated with this. There is heavy metals like liquid lead, mercury, and occupational exposure like hydrocarbon and arsenicals also associated with cardiomyopathy. So our patient in 2017 March diagnosed with left breast invasive ductal carcinoma with ER-PR positive with HER2 status 3+. At the time of diagnosis, before proceeding with chemotherapy, this is a chest X-ray showing no cardiomegaly with echo of normal LV systolic function. Patient underwent 4 cycles of anthracycline and based chemotherapy regimen, adriamycin and cyclophosphamide, followed by that planned for in view of her HER2 positivity. She was also planned for a 12-week cycle of paclitaxel with trastuzumab chemotherapy. At the 11th cycle, post 11th cycle, she presented with breathlessness and exhaustion associated with orthopnea. Then the X-ray echo at that point revealed moderate LV systolic dysfunction. So going to talk about trastuzumab-induced cardiomyopathy. Why is it important? Due to recent advancement in treatment, like targeted therapies for breast carcinoma, the survival rate of breast carcinoma has increased. So we are going to see patients with complication related to these drugs are also complication related to their long-term surveillance. Proposed mechanism for this trastuzumab-induced cardiomyopathy is neuroglin is an epithelial growth factor-like molecule that binds with HER4 receptors, thereby causing dimerization along with HER2 receptors. They activate GPCR pathway, thereby activating ERK1/2 pathway, and also they activate AKT pathway that decreases reactive oxygen species, increasing the cell survival. This trastuzumab will bind with HER2 receptors, thereby preventing this dimerization. Preventing this dimerization will increase reactive oxygen species, thereby increasing the oxidative stress. Also, this doxorubicin will also increase the oxidative stress, thereby increasing chances of apoptosis and heart failure. Risk factors for this trastuzumab-induced cardiomyopathy is where age more than 60, more than 30 kg, hypertension, or previous or concomitant anthracycline use, previous left ventricular dysfunction, and previous radiation therapy. Monitoring during course of treatment and before treatment, the guideline recommendation from American Society of Clinical Oncology: asymptomatic patient at risk for cardiac dysfunction, LV ejection fraction should be monitored at baseline and deemed necessary by the physician treatment for both localized and metastatic disease. For individual with signs and symptoms concerning of cardiac dysfunction, diagnostic assessment of LV ejection fraction is recommended during and after treatment. The guideline also recommends those who are asymptomatic to follow the echocardiograph after 6 and 12 months of completion of trastuzumab therapy. When to stop trastuzumab therapy? If patient develops symptoms during the course of treatment, we should assess LV function. If it is less than 50%, we can wait and repeat the echo. If it is less than 40%, that is drop of 10% below the baseline, we should stop the therapy. Prevention: how to prevent to minimize the sequential or concurrent use of anthracycline. As I mentioned in the mechanism, concomitant use of anthracyclines could increase the risk of cardiotoxicity. There are studies shown that AC inhibitors and ARBs and beta blockers has no role in primary prevention. Even guidelines doesn't recommend the primary prevention with beta blockers or AC. This is some RCTs, 5 RCT studies showing role of beta blockers, AC inhibitors for primary prevention, which showed no much of a benefit. Treatment wise, same as in management of heart failure, the first line heart failure medications such as ARBs, AC inhibitors, beta blockers, or diuretics has a role. Also, the newer heart failure medications such as neprilysin receptor antagonists like sacubitril, valsartan, and funicurin channel blockers like ivabradine is also shown.
Thank you, Dr. Lino. Are there any questions from the audience? Okay, we'll quickly move on to our last presentation by Dr. Sivaranjani. Okay, before that, I think we have some